Yeah, you can see that. This is the high portal looking down. Now, if you put it here, lower, what you do, you'll be in the fat pad too. You'll be struggling. Every time you move your scope, your fat pad will be pushing into the notch and you don't see a damn thing. Above the fat pad, look down, you see everything. You'll see better now. Again, if you look high, you can see the perspective. This portal coming in, looking at the insertion site this way. And again, you can see the meniscus, lateral meniscus, attaching to the ACL, and the vascularity coming. You can see coming in here. You won't see the vascularity, but this is where it's going to come in. And you can see the tibial spine on both sides. And now this patient have a big notch, so you can see the insertion site okay. In fact, you can see the PL bundle right here. You can see the PL bundle right there. You can see the insertion site all the way down here. And this is why people say this is not important. Look at that. This damn thing is all the way to the reticular cartilage below, all the way to below, okay? All right, you can see this is the PL, and this is the AM. You can see the septum between the two bundles right there. See that? See right there? And this is where the blood supply came in, and where the stem cells, come in and help, the ACL. That's fine, okay? That's fine, okay? Now, I'm going to change portal. I'm going to put in the middle portal right now. And you can see, again, you can see basically this is the PL side. This is the AM side. And this is the, the two bundle right there. Right there, okay? And if you're going to do the reconstruction, this come all the way to the edge, by the way. Now, the other one doesn't. So this one has a very big femoral side insertion. You understand? This one all the way to here, all the way. You can see it really well. All right, now the other thing I want to teach you is this. I'm going to put on the lateral portal again. Now, no, don't do anything yet, okay? So if I'm going to put my probe right here, if somebody's going to internal rotate the foot, there's no foot here. It becomes tight. You see that? Relax, it's loose. Internal rotate, now tight now. Now this is the behavior of the PL bundle. It should become tight if you internal rotate it. Why I do that? Because I have some cases the PL bundle is torn. It doesn't look torn sometimes. You have to do this. The patient have an injury, hemophagocytosis, everything. You go inside, it seems to look normal. About 2 months later, it's not normal because that thing is torn, PL only. The AM is intact, okay? And the AM, you can do a draw, for example, to do that, okay? So again, now, if you look at this way, let me measure first. Let me measure this. I'm gonna put a ruler in. This is $50. If you buy today, it discount $25, right? Oh, no charge.
Say 10.
All right. Now, you put it, again, you have to put it, the ruler have to be on the plateau. If you put this portal too high, you cannot measure it. So let's look at the insertion site on this side. This is almost a 16, 17 on the lateral side, okay? And now, usually I'll cut it. I cut it with a knife right here so I can measure it better. So the middle part, just estimation is a good 18, and this side is about 16, all right? And if I'm going to look at the notch, look at that. This is a 20th notch. It's a very big notch. If you're going to do a notchplasty, in this case, you should go to jail. Okay, it's a very big notch. All right, you shave your head, okay? All of you shave your head, you do notchplasty. This is what you're doing. Here, this is 18. This is a 10. The height is 20. The height is 21 or something like that. So if you look at it from the central portal, this is a very big notch. Look at that. This is a very big notch. And if you're going to do any notchplasty on this one, you commit, Now, how do you determine what you do to your tunnel? Now, if this case is acute cases, you'll see the blood supply coming in here. You can see the changes already. Now this is where the PL bundle is. This is the lateral meniscus, anterior horn, okay? So this is the PL bundle. This is the AM bundle right here. And this is the middle is where the single bundle should be, okay? You can see the septum between the two bundles right there, okay? So if you think the ACL is just C-shaped in the front, in this case, you're already wrong. Look at that, it comes all the way to the back in cases. Okay, before I move along, I'm going to do the next knee. Okay, let's move to this knee. Okay. Again, I'm going to look down now. This is, if you look at that, now this one is interesting. This one has a very big ligamentum mucosa. I think about 10 minutes to shave it up. In fact, I was worried there's no ACL when I go in this knee. How old is this patient, do you know? 70, okay? But I was worried. But it look, it's not bad. It's not bad, okay? At all. Again, you can see the central one coming like this. And you can see this portal coming this way. All right? Above the meniscus, you can bend the knee a little bit. If you bend the knee, open up so you can drill better. Understand? You have more room to drill, okay? All right, good. Again, you can see the meniscus right here. If the patient is alive, you'll see blood supply going up this way. All right? I'm going to do the central part. Again, you can see pretty good. Again, you can see this is the meniscus. So this is going to relate to the PL area. And you can see that you see the fatty changes starting to form on this one. This part is going to relate to the AM area, and this part is the central area. Okay, I'm going to get a knife. Come into here. Now again, this is to be quite flat. Now normally I can see the vascularity. I'm gonna preserve a little bit of this leaf right here. See that? A little bit. I'm gonna preserve this area. See that? This is a little bit degenerative changes in the back already. Fatty changes. Then this is why SIBO say it's all C-shaped right here. But this is not really, okay? You can see the whole thing is there, but it's start to have some changes. So again, if you look at that, you measure that, my God, this is much less. 11. What's the last one? About almost 16. Central is about 13. Medial side is about maybe 11. Anterior pec is about 8, maybe 9. Central is about 10, 11. The back part is about 8, okay? So let's do it, okay? So essentially, this is the meniscus right here. You can, get the PL side. Let's do the AM side here. And if you're going to do a middle, right here, come the middle side, okay? Right there, okay? This is where your, ACL should be. And you can have some idea, Remember the last, look at that. This one is 10. This one is about 14. 14, okay? Middle is 15. Top is about 10.
You get it on later.
So this is 25. This is an A-shaped knot, right? This is a A-shape. Look at that. This is a little bit narrow, tall notch. A bit more narrow, but not really typical A, but tall and narrow. Tall, 25 tall. Yeah. So this is the ACL top part. If you pull it, this is the resting ridge, right? You can feel it actually, right there. The resting ridge is right here. Okay, this is the whole ACL right there, all the way to the back. Okay, so this is the central. You want to do the AM is okay, but this is too small. I mean, there's no room. If you do a 8 or 10, it's about the whole damn thing. Now, give me a ruler first. I'm gonna change portal and put a portal more mutually now. Okay. And then I'm gonna measure it. This is about a 10, okay? A 10. And the height is about 8 or 9. Now, if you want to do so-called AM, if you do it right here, you're going to do the whole thing. Not much choices you can do, okay? All right, you say you're going to want to do more AM, it's right here, but it's not too much more. This is all over the top position. From this central portal, this is more central, this is more AM. This is over the top already, so you're going to put it here or definitely not here. So when people say that central, they may put it here, you know. They have no idea where they put it. I'm just telling you. But the way we do it, you can see it well. Now, give me a thermal again. Let me clean it down even further so we can see it well. So I'm going to clean down even further so I can see it really well for you, okay? All right, so this is more central, maybe a little bit more AM, okay? So give me a stem and all. Again, this is over the top right here. Now, if you put a scope over the top, you can also see the articular cartilage in the back sometimes. And then it's not very good here, there's some scar. But the cartilage top part is also signify the end of the ACL too, okay? So this is a resonant ridge right here. I can feel it. Now let me just turn the scope this way too. Oh, this is interesting. You can see that? This is the top of the ridge right here, see that? This loop this way and this loop this way. Really good. So this is the ACL. Nothing is going to split on the other side. You won't see it this way. But now if you turn it this way, you can see the split between the two ACL and the no ACL side, okay? Again, I'm just going to do a, you can do it right here. You can do it a little bit right there, but not much room to go. It's only 10. This damn thing is only 10 wide, okay? All right? Now bend the knee a little bit. Yeah. Bend a little bit more, yeah. All right? And then just down here. Now see the ridge. You see a resting ridge right here? Really good. You can. If I put my thing here, you can see a ridge and boom, it drops right here. Now if you're going to put your scope higher, you won't see this. You understand? You can only look from it from below to see this ridge right here, okay? You understand? So you're going to, okay, you can bend. Now, like you say, people will draw a diagram. Oh, I want to AM, I want to think. But this one, you put it right here, you get the whole ACL. Now, I won't do anything fancy. I'm just going to drill a hole. I'm just going to drill it through. Normally, you bend the knee and all those things, or you use a curved drill, all those things. But this is as simple as I want to do it, okay? You can bend the knee a little bit. Yeah, bend as much. Yeah, just.
That's it.
Yeah, just drill it through. So this is the 8. You can do a 10, an 8, but 8 is almost a lot already. See that? I think this one is probably 80-90% of the femoral side. Go all the way. Yeah, good. Okay. Shaver. So this is the ACL right here. The way we drew it is a little bit oval. Okay, oval shape. Look at that. See that? You can let go. You can let go. You can let go. You can let go. Yeah. Yeah. You can. Yeah. Or you can bend it a little bit again.
Yeah,
bend it.
right.
You can see better. So it's oval shape. Really mimic the. You know why it's oval shape? Because you obliquely drew it. You understand? Hold it. Yeah. Now, so again, this is the PL area. This is the AM area. This is the middle area. Middle area equivalent right to the middle of meniscus. And remember, I saved this. Save this because on the top, the genetically come in, and the bottom, this is your lifeline. This is your lifeline for ACL. And in the old days, we drew the ACL this way. When we do transtibial, we never get it. This is why all those grafts look lethargic years from now. You have to be close to it for this to come in, to give it the stem cells, all those things coming in, okay? All right, this is your think biological. All right? All right, so again, this is PL. You do double window is PL, AL, and this is right in the middle. If you get 65 degree, you're going to get your tunnel longer. If you get 55, a little bit middle. If you get 45, it's going to be shorter. Also, 45 degree will allow you to do a transtibial sometimes too. All right? So this is why people think that they can do a transtibial. But in order to do that, you have to get your ankle higher and higher. what's going to happen to that tunnel? Become bigger and bigger. Are you there? Okay. Take this out and drew it up and see what happens. Yeah, drew it up. Yeah. See if it's good. See if true guy is good. Okay, good. Give me a pro now. It look a little bit posterior. It look a little posterior, but is it posterior? So does it come out a little bit in front here? Okay, I can feel it's probably more like here. Okay, it's coming out. See that? But if you look at it, it seems to be back. But I left the remnant a little bit for the vascularity. You understand? It's right here. Okay, now you look at it this way, then you have to look at it this way, and you can probe it too. You can probe it this way, and you can feel the insertion site to be more in the front. And this is right here on the 208. So like I say, you have to look 3 times. You have a dilator? Yeah, good. Okay, all right, that's fine. Get out. Yeah, now you can look at the insertion site. This is probably more like anywhere 60-70%, okay? See that? Now, hold it right here. Don't do anything yet. So again, you have to look 3 times. This is the lateral side. Now, you see this patient notch is so high, it will never impinge. Never. Look at that. So big. Look at that. Look at that. Okay, incredible. And you can look at it this way. Extend the knee. Slowly. Look at that. This is, but if your notch is 14 height, it will impinge and you're dead. Okay? All right? Okay. All right, Michael Jackson. See that? Do you have the song? No song. Black and white. Black and white. White and black. Okay, this is the new Smith & Nephew. $10. How about that? You can. This is shoelaces. This is shoelaces. This is, look at that. You can get as big as you can. All right, you can extend the knee. This is, we can probably put a 10 in because this is so high. Look at that. I mean, this is probably can put more, in if you want to, But I just put an 8 and you can do double bunny, things like that. So, like I say, this patient will have, this is anatomical in terms of, now, no, don't do it. If you look at the femoral side, I would say this is probably 80 to 90%. All right? But I think if you put this, show them, If you put this tunnel wrong, way high, it doesn't matter because the patient has a tight notch. So you can get a